for the invitation, John and the team. It's a great honor this actually is a great meeting, and it's my first one, but it's more of a free thinking than regurgitation of slides. It's analyzing the data that we have rather than just presenting it again. So teaching old drugs, new tricks. And my assignment was to talk about prolonging survival in early chemo-sensitive patients. I think that was meant to be hormone-sensitive, or at least that's how I interpreted it. So here we go. Here are my disclosures. And let's be honest, few, if anyone, thought Chartered was going to show chemohormonal therapy was going to impart a survival benefit in M1 disease, hormone-sensitive. Or at least it felt like that for the 10 years of conducting the study. People who would rather see the benefit with a less toxic agent, there would be a lot more adoption, a lot more comfort, and less anguish about using, if we had abiraterone and zalutamide in this space, rather than a cytotoxic. But the question is there benefit in using a horizontal approach, attacking multiple different biologies, rather than just vertical inhibition down the AR axis? And that's what I'd like to discuss. So our conundrum, and it's been brought up here a couple of times, we have two thoughts in 2015, tumor heterogeneity and precision medicine. So how do we reconcile these two opposing attributes about what we're supposed to be doing in our clinical trials, in our drug discovery, and in our basic science research? And by the way, what is precision medicine? Well, the president loves it, the press love it, the people love it, Oliver calls it apple pie, but we've got some, but what is it? Question, audience participation. Who agrees that this is the definition? Right drug at the right dose for the right tumor at the right time, implying it's just one drug. So actually we'll take a vote. Hands up who thinks that's the right definition. A couple of maybe yeses. Question 2, who believes this approach will eradicate cancer? Any hands? No hands. So let's go through the war on cancer as it applies to prostate cancer. We had the University of Chicago, Huggins and Hodges in the 1940s, finding about testosterone. There was the Manhattan Project going on at the same institution. What was the opportunity that was lost at this stage? Not applying the androgen ablation to the warmongers, and world peace would have ensued. Clinical observation leading to the discovery of the androgen receptor it's what ultimately came from this experience. Then we had the war on cancer, the 1970s decree, Nixon decree, and then we started carpet bombing with cytotoxics in a way. And then in the Obama era, we're back to drone strikes, but when we think about drone strikes, we do worry about friendly casualties, so non-heme toxicities, but we may not be hitting the actual drivers of it, and we're hitting the wrong targets at times. And so 70 years of precision medicine has been going on as we target the androgen receptor, but we haven't eradicated the cancer. And I think it comes down to this. Some cancers are multi-genetic, and others are uni or oligogenetic. So EGFR tyrosine kinase inhibition in some lung cancers, but not all. And other diseases like CML and GIST do respond well to single targets because they're driven by that. So I do think there's a lot to be said for horizontal inhibition, integrated therapy, as John Isaacs referred to. And then if we look at castration-resistant disease, we see that the dream teams on both the East and West Coast show that there is clonal evolution and there are multiple sets of mutations within a patient. And oftentimes there are there's both inter and intra-patient heterogeneity. So how have we addressed this in the past? And John Isaacs was raising the flag to say we can cure these cancers with integrated therapies, and we have done it. And these are the examples. Combination chemotherapy, combined chemo and radiation therapy for head and neck cancer, surgery plus chemotherapy for breast and colon cancer, lymph node positive disease, hormonal therapy plus local therapy in breast and prostate cancer. But what were the premises for these successful strategies that did actually eradicate cancer, then cure these diseases? Single agent anti-cancer activity of each agent, non-overlapping toxicity, and different mechanisms of action, speaking to the horizontal inhibition issue. And integrated therapies do work, but also I think they work better when we give them in an earlier stage disease. So we can cure micrometastatic colon cancer, but not metastatic, by and large, not metastatic disease. And here's some discussions about tumor heterogeneity as it applies to prostate cancer. So, well, let's be honest, prostate cancer has more than 50 shades of gray. I have not seen, will not read the book, but Oliver tells me it's fantastic. Sorry for some of these who've heard this joke before, but here's some examples of some patients just to emphasize how heterogeneous this disease is. A 47-year-old man presents with metastatic disease, and he gets randomized to hormones and chemo on the charted study. PSA goes down, but he has a PSA non-progressing tumor, AR negative, and then within a year, he's died of his disease with his liver being replaced. And then there's this other gentleman who, at the age of 67, is climbing rock walls, was put on charted in November 2011, did have low volume disease, and I saw him last week, and his PSA is 0.02. He sent this photo showing off, and I said to him, look, be careful, I'm worried about the survival curves on the low volume because I'm worried about competing risks. But some examples of intra-patient heterogeneity. So here's a patient with a sodium fluoride PET on the left, multiple lesions, and the FDG PET with only one of the lesions actually lighting up. So different biologies within the same patient with different tumors. And here is the results of the PET imaging. It was a very small pilot study. If you had high burden of FDG positive disease, and sorry, the Mac to IBM did some formatting changes, sorry about that. But basically, the blue curve are those who had low burden of FDG uptake, intermediate 1 or 2 in the gold curve, and the high volume FDG had basically no response to this agent. It was just a couple of patients, but it speaks to inter-patient heterogeneity in this disease called castration-resistant prostate cancer. So we've seen this, and we can see that there was a benefit for the high volume patients that was clear and early in the charted study. And basically, it looks like there may be benefit, but we need longer follow-up. And again, this speaks to prostate cancer being a heterogeneous disease. But the question I want to raise is the benefit in the high volume due to just a matter of the high volume patients have more events, and the events happen sooner, and you could see the effect from chemotherapy we're added to the hormonal therapy sooner? Do patients with lower volume of disease have less clonal evolution and more AR dependence and just need the ADT alone? Or is it both 1 and 2? Knowing cancer, it's probably both 1 and 2. So here's the hypothesis and the speculation I'd like to drag out. When we're giving hormonal therapy and chemotherapy, Alan Bryce gave beautiful pictures and discussed the intricate tumor biology, but this is Chris Sweeney's approach to that. It's simple. Hormonal therapy decreases the white cells and you're left with the red cells, and then you have earlier progression. With hormones plus chemotherapy, you have the white cells and the red cells to regress longer time to progression, and this ultimately led to overall survival. I used to have them as blue cells and call them blue balls, but that caused a bit of controversy because no one likes the blue balls anymore. Moving on. So what is the underlying reasons? I don't know, but this is a hypothesis. Chemotherapy debulks the AR negative disease, or the disease that's not driven by full-length androgen receptor that are responsive to abiraterone and enzalutamide, for example. And by using the chemotherapy, we actually allowed the second-line AR targeted therapies to be more effective. Hypothesis and speculation. So here, people said, well, that's the case. Well, this charted study, you can't believe it because it was the GTUG, I think it's pronounced GTUG, Nick Vogelsang, was negative. So the tale of two studies, theirs was negative, ours was positive. And people said, well, the study populations were different. Well, actually, when you look at it, they went back and redefined their patients by high volume versus low volume using the exact same definition. And the ADT alone arm in the high volume was 33 months for us, 32 months, and 35 months for the GTUG study, very similar. And the low volume, both groups had basically 4-year overall survivals of 70%, if not higher. So actually, the ADT alone arms looked the same. So the question comes, does early dose Taxa work better in France than in the US than France? Probably not. The chartered investigators got lucky. I don't think so. Patients in France and US differ. I don't think so. But I do think it was the access to the second-line hormonal therapies. So the Stampede trial raised the flag. The horses are thundering in to the rescue. Light Brigade, Stampede, did the study. It's a very complicated study, but we'll just drag out one of the arms of one of the subsets out of the 7 arms that are ongoing, namely the hormones plus docetaxel in the M1 patient population. And they basically had a survival benefit that was very similar to the ECOG study. And and working with this MRC team, they've already started an aggregate clinical data, and there's plans for individual patient data, but this is the results of the aggregate clinical trial data presented at the ECC by the MRC team. So basically combined all the studies and showed that there was a failure-free survival in all the studies, including the GTUG-15 study. And as you can see, there's a decrease in the time to progression, the decreased progression rate in those who got early docetaxel versus ADT alone in all of the studies, including the French study. And then when we looked at the survival, the only study that didn't have a survival benefit was the GTUG study. And the only thing that I can see is different, and this is a slide that Howard Scher has put together and presented at ASCO, is that when the studies were accrued, the French accrued their study basically before the agents were approved. Green representing the FDA approvals, and the orange, the European approvals. And you can see the accrual to Chartered and Stampede occurred during these approval processes so that once patients progressed, they could access these agents, which was not the case in the GTUG study. And if you try and tally up the therapies, we can actually see there was far more therapies in the ADT plus docetaxel arm versus in the Chartered study versus the GTUG. And I just draw your attention to the rate of use of abiraterone 92 versus 15 of 192, 92 out of 397, and that was of those who had actually progressed. So there was a lot more access to life-prolonging therapies, including cabazitaxel, abiraterone, and enzalutamide. So very briefly, docetaxel does work in a disease that has the presence of ARV7, a disease that may be autonomous of full-length androgen receptor, not responsive to anti-androgen therapy in this setting. And then we do have this in the slide of versions of it multiple times already, that the AR-targeted therapies do not work when you have this AR variant. So the speculation is the disease that emerges with a rising PSA after docetaxel is more AR-dependent and greater benefit with AR-targeted therapies, maybe. And here's some speculation to actually maybe support that. So there's a tram track, they're parallel for the time to PSA rise, the time to what we call castration-resistant disease, but one with a hazard ratio of 0.52, but the hazard ratio is even better for the time to clinical progression. That makes me wonder if the second-line therapies controlled the disease for longer from the time to PSA rise to clinical progression in the CRPC setting, because the agents were more effective in that setting. Again, speculation. So my conclusions, with 2 minutes to go. Precision medicine in prostate cancer, how close are we? We have been implementing precision medicine for more than 70 years by targeting the androgen receptor pathway. Deploying therapies earlier when less heterogeneous would be more effective, and I think that's what we should do. And so in that case, I have the honor of working with the Australian team, wrote the studies with them of Enzamet and Enzarad for that very specific purpose. My mantra is let's go forward by going backwards and bring these therapies earlier into the state of disease. And the Enzamet study does allow docetaxel use. So some patients will be getting ADT, docetaxel, and enzalutamide, and others will be, but if you're not a candidate, you don't get the chemotherapy part. I think this is the truth in advertising. We cannot ignore clonal level evolution, especially in patients with higher burden of disease and more advanced disease with greater heterogeneity. I think it's naive to think there will be a magic bullet. There are benefits with some magic bullets. So the DNA repair story with the TOPARP study and BRCA inhibition, PARP inhibition, I should say. There is the rare patient who has a PTEN mutation and a PI3 kinase mutation, has a fantastic response to PI3 kinase inhibition, but we need the biopsy to confirm the current disease. But at the end of the day, I think probably we need to be co-targeting multiple biologies at any one time for the majority of the patients. and the ADT docetaxel would be in support of that statement. So this is a slide I get asked, who do I treat with chemotherapy? Early in metastatic hormone-sensitive prostate cancer. High volume young patient chemo fit, I think it's certain. Even an elderly patient who's 75 years of age and has no comorbidities, I think it's very reasonable, who has high volume disease because he's going to die of his prostate cancer, to give it. I think the Stampede people have said anyone who's chemo candidate, regardless of their volume of disease, should get it. Other people propose it's only those who have de novo metastatic disease because they're driving the survival curves. I actually am a little bit more moderate on that. Sometimes I am moderate. So there is the young patient who has low volume disease and is in his 60s and he's due to live forever. I think it's probable, and I do offer it to them and have it as a conversation, but not as a mandate. And as one Frenchman once said, a benefit of the doubt to me. But an elderly patient who's not chemo fit and has low volume disease, there's no benefit. So thank you for your attention, and many people. And the key thing about the Chartered study and the Stampede study, by and large, it was a collaboration between taxpayers, the government, and the industry, and I think it's a great experience. Thank you very much for the great time. Any questions? Yeah, and Manuel, and Oliver, and John.
So you mentioned this meta-analysis that's not published yet.
Sorry.
But have you looked at the low-volume subset, because that may help to answer the question about should you give it to all patients who are chemo fit?
So that's the plan for the individual patient data, and bottom line is we need the individual patient data to do that meta-analysis and longer follow-up, and the Stampede didn't collect that data to be able to look at that. So it's a plan to try and work that out one way or the other. John.
So the use of cyclophosphamide to downregulate Tregs, besides its effect on the cancer directly, makes real sense to me. I mean, cyclophosphamide is a fantastic drug. Have you ever thought, I know, and you're already building a base. In other words, we're going to have to probably incrementally build up. So the question is, you've got a signal, you're going the right direction. Why not cyclophosphamide in that protocol?
Say for Enzamet, for example? Which protocol?
Yeah, well, the protocol where you're actually combining taxanes with androgen ablation early when you're ending up having the low volume disease. In theory, I think some of that separation is, again, the immune system, okay?
Yep.
And we know that cyclophosphamide has this nice effect of knocking down Tregs.
Right. So it's a cheaper version of the PD-1 inhibition in a way, and allowing for immune activation of sorts, yeah.
Bingo. Okay. Doesn't cost $100,000.
Small detail.
And it also has the ability, if there are some clones that are actually proliferating rapidly, which, when we talk about this small fraction of cells which can grow out, and we're talking to grow out in a period of a couple years, boy, they would have to have a pretty good proliferation rate to grow out like that. So maybe there are cells that are able to proliferate very rapidly. Certainly in the autopsy, in the end, we seem to have something like that. But cyclophosphamide would be a twofer.
Yeah.
It would be anti-proliferative and do the immune system. And I just don't know why it's not kind of built in.
Pragmatic reasons. But I think, I think when it's all said and done, we will get there with going after the multiple hallmarks of the Hannah Weinberg, and we're starting to do that now. And that's the conversation about horizontal targeting, I think. John.
Yeah, it was really interesting. I thought you said that when things were approved, because again, as sequence, it's fascinating. Though, part of it, do you think that again, two hypotheses? One, that if you look at both the Chartered and the Stampede, they actually had some people who were progressing before those drugs were, and then other ones later. If the chemotherapy had a higher proportion of people getting to when those drugs are available, the survival makes sense versus that they both could get them afterwards. Do you think that might be part of it?
Absolutely. Do you maintain a performance status for longer that you can get something? Yeah. I think there is a possibility, and the speculation is that the curves in Chartered, where we had the most access, actually occurred very early. And if you look at the Stampede study, their curve actually separates a little later, at about year 2. Ours separated at basically the 12-month mark. And then so we got rid of the early progressors who died quickly. And even if you look at the French study, they actually have a late separation, if you wonder. And you wonder if it's when their drugs came in, but that's complete speculation in small numbers. But their curves are the same until after the median for some reason.
Could there also be a theory that if you look at the horizontal, that you've actually cleared out, the potentially the bad
Absolutely.
actors, and then it is just these potential hormone sensitive ones that are still around, so then when they could get other hormonal therapies, they
That's
could.
my very simplistic view of the world. I'm with you.
Good. And I just want to let you know, just sorry, really quickly, is that if there is oh, you got it all? Okay, then I don't need to say anything.
Okay. Walt's chomping to get on, but
Where are you?
one of the things that you've done, I just wanted you to comment really quick, Chris. The ice cap initiative is something that we haven't discussed here. Could you give the group 30 seconds on ice cap, just because I think it's important, and
So,
some
yes.
people may not know about it.
So ASCAP version 1.0 is we've got we've asked for every clinically localized clinical trial data set. So right now we have a data set of 21,000 with 2 data sets to come in. So we'll have 22,000 individual patient data to look for an intermediate endpoint, say 5-year disease-free survival post-local therapy. Is that a surrogate for overall survival? So we can accelerate and get readouts on Enzarad, and then if we can do that, then do the next study with cyclophosphamide or something like that. So we're on the chart. Walt Stepler.